This is the Etiology podcast. I am your host, Elka Kubaku, licensed social worker and psychotherapist. In this podcast, we explore divisive issues around food, health, and body image with the goal of mending relationships within the eating disorder recovery professional community and creating a space where a multiplicity of perspectives can coexist harmoniously. This podcast is uncensored and encompasses the political and ideological spectrum. If you believe something you hear is harmful or misinformed, please be respectful to the speaker. And also, feel free to reach out about recording another episode on the same topic from your vantage point. My hope is that if, as professionals, we can hold each other's stories with respect and compassion, we'll be better able to do so for our clients. Does weight affect health? For many years, the scientific and medical communities assumed the answer to this question was an obvious yes. After all, studies show correlations between higher BMI, body mass index, and various medical conditions, one of which, PCOS, polycystic ovarian syndrome, is the topic of today's episode. When we look at studies showing a correlation between weight and PCOS or other medical conditions, there are two key questions. Number one, does weight cause the condition? Or is there a third variable that influences both weight and the condition? Number two, are the treatment recommendations based on the association between higher BMI and medical condition helpful or harmful to the patient? In this episode, Lauren Hirschhorn-Tieu shares her experience as someone diagnosed with PCOS and prescribed a rigid weight loss diet. She discusses the negative impact of the diet on her quality of life, eating patterns, social life, and self-perception, along with the lack of substantiated impact the diet actually had on her PCOS. When Lauren talks about the meal plan she was prescribed, we also briefly touch on censorship, trigger warnings, and the impact of sharing specifics about food restriction. We settle on sharing the specifics and allowing you, the listener, to decide whether you want to listen and to process your reactions if you choose to engage. I debated whether to cut this from the episode. On the one hand, in the context of our conversation, the particular snack Lauren was prescribed was legitimately not important. On the other hand, it touches on a broader question about the recovery environment we create. To what extent are we responsible for monitoring ourselves to shield one another from potentially painful or triggering information versus sharing our stories openly and in enough detail to bring them to life, while also validating, owning, and processing our reactions to each other? Lauren is a non-diet, health at every size aligned registered dietitian and owner of Note to Self Nutrition. Lauren started her career in the clinical side of nutrition, working in hospitals and skilled nursing facilities, which provided her with a solid medical foundation and a deep understanding of the complexities of the body and the medical field. She now combines that experience with her Hazel-aligned approach to help clients navigate medical conditions like diabetes, chronic kidney disease, and hormonal imbalances, all while supporting their relationship with food and their bodies. Having her own history of struggles with nutrition and body image has shaped Lauren's gentle approach to nutrition therapy. She deeply understands the grief that comes with a changing body and the pressure to fit into societal ideals. She also recognizes that her own lived experience is just one part of the story, and she continues to learn from the diverse clients she works with. At the heart of Lauren's work is a desire to help clients reconnect with their authentic selves, the person they were before diet culture took hold. She believes that the joyful, carefree parts of ourselves are still within us, waiting to be rediscovered. Hi, Lauren. Thanks for joining me today.
Yeah, thanks for having me.
So, can you start by just telling me a little bit about what you do professionally in the eating disorder recovery space?
Yeah, so I am a registered dietitian. I've been a registered dietitian for about 5 or 6 years. I'm like, what year did I graduate? About 5 or 6 years, and I'm the owner of Note to Self Nutrition. So it's a private practice outpatient, I guess, group, but it's really only me at this point in time. Nutritional counseling group. So I work with clients virtually and in person, kind of working on their eating disorder recoveries. I do get some folks who do not have eating disorders, but are looking for more of a health at every size aligned approach to nutrition. So individuals with PCOS, fertility concerns, diabetes, all sort of stuff like that. So I kind of like a mixed bag of clients and different things to work on with them.
Cool. So, our topic today is looking at PCOS and fertility through a from a Hazeline perspective or health at every size perspective, can you give me a little bit of an overview of sort of the landscape of how weight is seen in relation to PCOS and fertility, what you've encountered and where you stand now?
Yeah, such a good question. So, PCOS, for people who don't know, stands for polycystic ovarian syndrome, which is basically like at its core a metabolic condition that can make a lot of things difficult, fertility being one of them. And individuals with PCOS, I think there's a lot of shame that comes when they get a diagnosis like that. For a long time, and I myself have PCOS, so I kind of have my own experience with it too. But for a long time, a lot of the medical advice for PCOS management was very and is often still very weight biased. And a lot of the recommendations, um, I personally and professionally feel kind of set individuals up for having disordered relationships with food and movement and all of those things. So there's a very big tie. There's been some studies, I don't have exact statistics that kind of show like a lot of individuals with PCOS do have co-occurring eating disorders. Which came first,
Mhm.
or the egg? Who really knows? But there is a strong tie between the two. And also when it comes to fertility treatment, because PCOS can and often does affect like your reproductive hormones and the balance of them, it can make fertility difficult. It can make getting pregnant difficult because it throws off ovulation. So what
Okay.
happens is often people get those like very weight bias recommendations from their doctor, thinking like, I'll manage my PCOS that way, and then I'll get pregnant. But those recommendations, all they do is exacerbate symptoms. And then we're still in the same spot of still having PCOS symptoms, still struggling with pregnancy, um, and still probably struggling with shame and discomfort around the diagnosis itself. And I've just seen a lot of that, like in my own journey and with my clients and the treatment that they get from some of their providers. And I think there's just a lot more work we have to do with PCOS in the medical
Yeah.
field at large that I don't often see happening, unfortunately.
Mhm. Can you name some of those weight biased messages that you've gotten, or some of the common ones that you see clients getting from
Yeah.
medical providers?
Yeah, so even just diagnosing PCOS. So um, there's kind of like, and this is just I don't have studies to prove this. This is just kind of based off of what I've seen. I feel like PCOS gets very overdiagnosed sometimes in individuals with larger bodies because doctors are just like, oh, you have like irregular periods and you're in a larger body. It must be PCOS. And what
Hmm.
I've seen is that oftentimes, like these individuals might just have an eating disorder or be malnourished because eating disorders come in all shapes and sizes. There's not like one body type that can have an eating disorder. So
Hmm.
there's this like overdiagnosis that we see for larger bodied folks. But then also on the flip side, there's like underdiagnosis for individuals in, traditionally straight sized bodies where they're having all of these hormonal issues and irregular cycles and concerns, but they're like, oh, they're not in a larger body, so it must not be PCOS. So
Hmm.
that's one of the things.
Yeah. Okay.
Oh no, go
There's
ahead.
another. There's another that you were about to say.
Just in thinking, like, even when it comes to fertility, I know sometimes doctors, and this is more broad, but because individuals with PCOS may seek fertility treatment from specialists, like, I've definitely seen specialists tell clients, like, you have to lose weight before I'll even, start you on whatever fertility regimen they have for them, which again, like if we're trying to get pregnant, like we want our body to be in the most ideal state. We don't want it to be malnourished or not getting nutrients. So there's been a lot of that too, of kind of like a power dynamic of I'm not going to help you get pregnant until you lose weight. Um,
Mhm.
so that's been really hard, I know, for some clients and individuals to deal with.
So there's an assumption among medical providers that if you're in a larger body, you're more likely to have PCOS, and if you're not, you're not. Is there I'm just, as I'm hearing that, wondering where it comes from. Is there a correlation between BMI and PCOS? Is it one of those things where the question that becomes, is it correlation or causation, or like what's the beliefs um, or facts, if there is such a thing, underneath this debate about
Yeah,
whether weight matters or not?
such a good question. I think it's probably a mixed bag, as most things are, to be honest. But I think in some cases, like insulin resistance can be a big piece of PCOS. So insulin resistance, I guess for anyone listening, I'll give a little background on what that.
Yeah,
So
define medical terms you use in general.
yeah, so basically what that means in our bodies, right? Like if we ingest carbohydrates, they break down into glucose or sugar and that goes into our bloodstream, and that's kind of the number that gets measured when we say like what's your blood sugar level, like on lab work and stuff.
Yeah.
Um, Usually our pancreas will pump out insulin to then get that glucose into our cells to use for energy.
Yeah.
If by chance our cells, I kind of use the analogy of there being a door on the cells and insulin opens the door. If our cells are more resistant to insulin, that door doesn't open as easily. So all of that glucose that's in our bloodstream can't get into the cell and then give us energy once it's there. So what we find is blood sugar numbers in our bloodstream stay high because they're not getting into the cells, and our pancreas just keeps pumping out insulin. So then we also have high levels of insulin. And why that's important to kind of recognize the dynamic is that insulin is a growth hormone. So the more insulin that is pumping through our body, it can cause weight gain, just from kind
Okay.
of like a scientific standpoint. So there is like a connection if insulin resistance is happening, that we may be in a larger body, we may gain weight and struggle to maintain weight. That's often something individuals with PCOS have talked about. I will say
Mhm.
there is still, I don't love this term, but people may have heard it in the past, like what they used to call lean PCOS. Again,
Okay.
favorite term, but it's out there. So I think it's important to address it. And that was basically trying to describe the population that still has PCOS and has this, you know, imbalance, for lack of a better term, of hormones, but might not have the weight gain piece of the puzzle, but still has a lot of the other symptoms. Um,
Okay.
and I think that there just needs to be more research on it. There's been some studies that kind of say that regardless of body type, if you have PCOS, you probably have some degree of insulin resistance. What degree
Mhm.
that is may vary. Um, but I think as with most things, women's health, like there haven't been a lot of studies to really look into like, is this an entirely different diagnosis when, we're struggling with weight versus when we're not? Like, is it stemming from somewhere different? We don't really know.
Mhm. Okay, so with PCOS, this is starting to sound a little like diabetes. Can you like highlight the differences and overlap for me? What I hear, so there's you take in sugar broken down to glucose, then insulin helps that become absorbed into cells so they can be used for energy. When there's a malfunction in the body's ability to, is it that door you described? So the insulin is being produced, but it's not able to absorb and break down the sugar. Is that
Yeah, so insulin's kind of that, like, if we want to call it a doorman, that opens that door. And it's
okay?
just for whatever reason, it's not able to do that efficiently. So the sugar, the blood glucose, I use them
Yeah.
interchangeably. Like that's not able to get into that cell and give us energy.
Okay. So that leaves you with higher blood sugar, higher insulin, and less energy.
Mhm. Yep. And it does sound very similar to diabetes because it is kind of connected, we'll say.
Mhm.
It is a risk factor for development of diabetes. I think that's also why it can be a really scary diagnosis, because insulin resistance at its core, like I was saying, the pancreas keeps pumping out that insulin. And type 2 diabetes is basically when the pancreas gets overworked and gets tired and can't do its job efficiently anymore because it's overworked. It just
Yeah.
can't anymore to the degree that it has to. So I'm not saying everyone with PCOS will get type 2 diabetes. That's not how all of this works, but it is a risk factor. So it's definitely something that um, makes people concerned when they get diagnosed as well.
Mhm. What are the symptoms that led you or tend to lead people to seek out a PCOS diagnosis?
Yeah. So when I was diagnosed, it was probably like 11 or 12 years ago, and people were not talking about PCOS in kind of the way that they are now, where people know more about it. And I would say even like 3 or 4 years before that, I started experiencing symptoms. So there's kind of, again, because PCOS is kind of this broad diagnosis too that can present in various different ways. There is a kind of broad sense or scale of symptoms, but sometimes I guess let me start back with just the three criteria of PCOS diagnosis, and then you'll kind of see how the symptoms line up with that. So to get diagnosed with PCOS, you have to hit 2 out of 3 of what they call the Rotterdam criteria. So the Rotterdam criteria are they call it like irregular ovulation, but essentially it just means irregular periods and cycles, whether having really long cycles where you're bleeding for, much longer than you should be. I've had clients that have experienced that for like 2 weeks to a month, or you're just not getting frequent cycles. Like you could go months at a time without having a cycle. So just irregular cycles in general. Increased androgens, which androgens are just like, what do I want to call them? I always call them like male sex hormones, essentially, but it's
Yeah.
really testosterone, DHEA, those sort of things. So increase in that would be in symptoms like excess hair growth, kind of people, because most individuals diagnosed with PCOS are assigned female at birth, they're traditionally not growing facial hair, but that can be a symptom of excess androgen. Hair loss in kind of more of that like male pattern balding kind of way
Okay.
is a symptom because again, we're having excess of those androgens in our bodies. And
Yeah.
the third criteria is polycystic ovaries, so having cysts on our ovaries. There's still a little bit of debate of whether or not that should be part of the criteria because people have cysts on their ovaries often and don't have PCOS,
Yeah.
but that was kind of why they say you only have to meet 2 out of the 3 criteria to get a diagnosis.
Mhm.
Um, so knowing that you only have to meet 2 out of 3 of that, it is kind of interesting when you think about how PCOS can present. Like someone could meet all 3 of those criteria and have all of those symptoms, or they could, have polycystic ovaries, which wouldn't really present outwardly, and then maybe irregular cycles. Whereas someone else might have a lot of those increased androgen symptoms of, facial hair growth and things that are more outwardly presenting.
Yeah. As you're talking, it seems to me that there can be a situation in which someone has those symptoms, but it's not really disturbing, or they don't even realize there's anything going on. What what was the thing that motivated you to look for a diagnosis, or what is the thing among those that people find most disturbing and is an indication to them something is going on here?
Yeah, it's so interesting because PCOS is kind of coined as a diagnosis of exclusion. So if you see a really good specialist that knows what they're doing, they're going to be looking at all sorts of things like your thyroid and eating disorders and nutrition and your pituitary gland, like all of these things, not my entire scope, so I don't know everything about them, but these things
Yeah.
that really look similar to PCOS, but are not PCOS at their core. So
Okay.
they're going to look through all of those things first. And if they find nothing, then they're kind of like,
Mhm.
okay, PCOS. So it is really interesting because if folks don't see a specialist, or like you said, like some of these things might not be disturbing or they get pushed onto something else. Like I know some folks might have irregular periods when they're young and they just get put on a birth control pill for years
Right.
and may never know
Mhm.
that they have PCOS because we haven't really tested for that. We put a Band-Aid fix on it. Um, so it is really interesting to see um, how people struggle with it and how some people don't. For
Yeah.
me, I was in high school, and there's also, again, because so many things can mimic it, um, there's still kind of some thought between myself and my providers of was this, more nutritional based malnourishment, and just adolescence, irregular cycles, or is this really PCOS? And
Mhm.
who knows? We can't go back 15 years and really
Yeah.
look at in depth from that time period. But I had very irregular cycles, like to the point where, and I know for a fact, like I probably was not ovulating, but I was bleeding every 2 weeks, which is, again, irregular in
Okay.
nature, abnormal.
Mhm.
And it was never my
Yeah.
normal, but like it had drastically shifted. I think that's one thing to keep in mind too. Like sometimes people will be like, my cycle's so irregular, it's 40 days, but it's always been 40 days for them. That might just be their normal. Versus if
Okay.
someone came and said, my cycle's always 28 days, and the last 5 months it's been 40 days. That's
Mhm.
something to look
Is the is the cause or the underlying cause of PCOS known, or is it one of those things that sort of you look at a group of symptoms and know that it happens to people, but don't really know why?
Yeah, I don't know if they know like the underlying cause per se. I think a lot, I always, I don't want to like make it the scapegoat, but I feel like I always come back to genetics being a big tie in things. And there was a study I read once where they were like, it is pretty likely if you have like one relative that has diabetes, or if you have one relative that has PCOS, like you're at more of a risk to have these conditions just because of genetic predisposition. So
Mhm.
genetics are a big factor in it, but I haven't seen, and just because I haven't seen doesn't mean they don't exist. But I haven't seen any studies really diving into like what is the genetic predisposition of this, like what is the
Mhm.
sequence, what it like all of that sort of stuff, not in the sense of we have to prevent it, but just to learn more about it. Um,
Yeah. I'm wondering more about because when you say it's not something that you have at birth, it's something that turns, I don't know, like the flip switches at some
mhm.
flip switch, yeah, at some point. So what I'm wondering is what is the thing that turns it on? Because that leads directly into the question of when people are talking about weight loss as going along with it, or is weight loss given as a prescription for it, or just as an indication of it?
It is. I'm not a fan of that recommendation, obviously, as someone who's Haze aligned in my practice.
Yeah.
I think weight loss can be like a result of some of the interventions we put in place. And it can happen like if we're, again, like insulin is a growth hormone. So if we're managing your insulin resistance and that insulin level in your blood is decreasing, then like, yeah, we might see weight loss. But the weight loss is not what's managing your PCOS. It's the insulin decreasing and your blood sugar management. So that's where it's kind of like, I don't think the education piece always gets across to clients. Like, if a doctor's just like, you have to lose weight, then someone might go on some crash diet from an influencer and not really be managing their PCOS symptoms. They're just changing a number on a scale.
Okay, so that is the essence of the argument then is it is a correlation versus causation. Like we know this is more common in people in larger bodies. Is it that weight is causing it, or is it just that weight is a byproduct, which is like what you described?
Mm-hmm.
Then in terms of treatment, then I mean weight loss is such a complicated recommendation for so many reasons. So one piece is this actually like you're describing, is this actually causing the PCOS, or is it just a byproduct of it, in which case addressing the weight loss doesn't really have to do with addressing the problem. It may or may not shift things. And then the other piece is when you're giving weight loss recommendations, how is that actually affecting the person? And that's
Mhm.
when you get eating disorder being triggered, and um, just all of the many studies showing that weight loss attempts are massively unsuccessful.
Yeah. Yeah. And even like I think, and not that we're going deep into this because this is not the point of today. But
Yeah.
even I know some people will jump at the GLP-1s for management of PCOS, and there's
Hmm.
some talk about how it can be helpful. It's helpful with diabetes. Why wouldn't it be helpful with PCOS? That's very tied to that. I think they need more studies on it before we start jumping down that bandwagon. But in the same way, I'm like, there's so many other ways and avenues that are less invasive that we could
Hmm.
try first that would help like maintain that healing relationship with food and your body, that like maybe we don't have to jump to that extreme one first. But I know in traditional medical spaces, like that one gets pushed first over many other things.
Yeah, that's the weight bias.
Mhm.
What are those less invasive things? What does treatment for PCOS typically look like aside from, and what does having a diagnosis give you?
Yeah. So treatment again kind of varies depending on how it's presenting for the individual. So like those three criteria, let's just say they have all three of them, just to talk about the overall broad sense. From a nutrition standpoint, it's a lot of blood sugar management. So there's a lot of emphasis, not in an obsessive way, but emphasis on increasing our protein, because when you consume carbs with protein, helps balance that, blood sugar spike versus carbs by themselves. I'm very
Okay.
flexible with clients. I'm obviously like, if you want to have carbs by themselves every now and again, like that's your choice. I'm just here to present the information and the education. So definitely like focusing on protein more so at our meals, and getting that balanced blood sugar. There are some supplements people will use, like inositol. The brand name is Avasitol. There's a lot of other side brand names. I would only trust the Avasitol brand. And I
Yeah.
it in my own life too, like they are a reputable company. Um, but basically, studies have shown inositol is a vitamin-like substance, and there's various different types. There's like myo-inositol, D-chiro-inositol, different ones, but they've found that this 40-to-1 ratio, and I always mix up the two of them, but it's D-chiro and myo-inositol. It's a ratio between the two, that perfect ratio that's in Avasitol kind of acts as a WD-40 on that door of
Mhm.
the cell. So it
Okay.
helps the cells open that door easier to get that glucose into the cells. So essentially, they call it an insulin sensitizer. It's making the cells more sensitive. Um, and it's a flavorless powder. There's minimal side effects, if any, to it. So that's usually what I'm recommending for clients to try out first. Um, it's not like hard to bring it into your day. If you're drinking water, like just throw it in there and you won't even notice it's there. So that can be really helpful. Even just lifestyle. I know it sounds so silly, but lifestyle of stress management. Stress is very inflammatory. PCOS is kind of an inflammatory condition. Our body's not functioning properly and efficiently, which can increase inflammation. So stress management, whether that's like yoga or therapy or all different, I'm sure you know more about stress
Yeah.
management than I do. All of those things can be helpful. I always encourage clients to increase omega-3s. Those are like your antioxidants and also anti-inflammatory agents. So like your
Yeah.
olive oil, nuts and seeds, all of that fun stuff. And then increasing fiber. Fiber is really helpful for our gut health. We're learning more and more every day about how gut health impacts the body as a whole. So that's kind of more of the nutrition piece I focus on.
Yeah. So if I was understanding like what's happening in PCOS and how it's typically treated, you have the things that treat the insulin resistance. So that would be things like the supplement you mentioned and having protein with carbs. And then there's the lifestyle changes that affect some of the more broader impact of that insulin. Is it the broader impact of the insulin resistance?
Yeah, I would say usually, and just any time, like I said, our body's not functioning efficiently, there's going to be an increase in inflammation. I think
Yeah.
a lot of the recommendations, like work out more, decrease, your intake of carbs, like all of that just breeds inflammation in our bodies.
Yeah.
So
Yeah.
stepping away from those things can be really helpful. And there's other like scopes of practice and providers, like if someone's struggling with hair growth, like they might go see a dermatologist that will help with that. Obviously, PCOS management at its core will help with that too. But sometimes people can go seek out other providers for additional support in those areas.
Yeah. Some aspect of managing the symptoms.
Mhm, mhm.
Okay. And that's where weight loss recommendations get thrown in, which they're often, anytime there's like a lifestyle shift or something, weight loss is sort of thrown in as one of those. Can you tell me about, can we go back to your story and dive in a little bit there? So tell me about when you were diagnosed with PCOS, what extent uh, you were either judged or assessed for weight or given recommendations based on it and what that looked like.
Yeah, so it's so interesting to me as someone now who obviously is more hazel-lined than I was in high school and early college, and has a better understanding of it. Um, Even though back then, like I very much thought I was in a fat body, I was not in a fat
Mhm.
body at all. I think that's really important for me to note. Um, in kind of just the treatment that I got. Like I physically was not in a fat body, but even though I don't believe in using BMI, my medical providers were using it, and my BMI
Mhm.
was, above the normal range. So
Okay.
they were utilizing that, and it's always interesting to me, kind of like the very fat phobic and weight bias treatment I was getting when I didn't even exist in a fat body. It just, you know, makes me think more so and also just have more empathy for folks who are truly in fat bodies and the treatment that they may be receiving from their providers. Because I think we have a lot of fat phobia in the medical field. We know that. Um, and it's just always interesting to me, kind of when I would go to visits and kind of like how well I was doing was always based around had the scale gone down or not, which
Mhm.
and when I was diagnosed, I was a sophomore in college. I was living the traditional college student
Right.
life. I was not living the very like PCOS
Mhm.
management kind of life. I
Yeah.
would argue that as a millennial in college and, the mid 2000s, I guess we call it, like most things we're doing were inflammatory based in college.
Yeah.
Like most of my visits were not great. Like they were like, I don't want to say that I was shamed entirely, like someone, like no one said to me specifically, you're doing a horrible job, but there was just this underlying feeling of shame and like I didn't meet the goal. And like I think a lot of people think of like
Mhm.
weight
What
loss.
was, okay, so they were monitoring your weight and like sort of checking like were you at the correct range?
And like, I know from a food perspective, I did see a dietitian and I will credit her because she, in one sense, she was very
Mhm.
much like, you didn't do this to yourself. Like, this is genetic. Like, you had no control over that. So I credit her for that. And I did appreciate that at the time because I think a lot of people, especially as a young person, kind of felt like, I did this to myself because of how I ate or how I lived or whatever. Um, but then proceeded to kind of give me a meal plan that, as a dietitian now, with all my knowledge, I was like, that's heavily restrictive. Like, I don't even want to say what it is because I don't want to give people ideas, but just a very heavily restrictive diet. Um, and I can see clear, I remember clearly like making the snacks and being like, this is not satisfying at all. and feeling
Mhm.
like so disconnected from my body and feeling like my body's working against me because you're telling me this snack is supposed to
Mhm.
be a good enough snack, but like I'm not feeling that way. So something's wrong with me as opposed to something's wrong with this very restrictive diet you just gave me. Um,
Yeah. So you felt very unsatisfied. Was that like you were still hungry? Was it just like I need more variety? I'm not able to eat things I enjoy. What was that dissatisfaction?
I think it was kind of all of the above, honestly. I think it was just not being satisfied, one. Like,
Mhm.
which I know that doesn't describe anything, but just kind of like that's not really what I want for a snack. And then also not even quantity wise, like not being enough, like one side was I'm still craving food after this, and then the other side was like I'm also still hungry after this.
Yeah.
Like I'm not feeling like an energy boost after having this snack.
Yeah. How rigid was the meal plan? Was it a like you will eat this amount of these things every meal?
Yeah,
Okay, that's
and I'll admit I didn't really follow it that long or that perfectly for that reason. But it was kind of, I would say, I'm trying to think back. I don't think it gave some ideas for meals, but I don't think like I was still living at home slash at college. So it kind of like going back and forth like on breaks and stuff. I don't think I followed it for the meals specifically. I
fine.
think I followed it more so for the snacks. Um, which over time, again, I was like, the whole kind of, it reminds me so much of diets and diet culture and that cycle of like, I'm going to do this and everything's going to be perfect. Like, I kind of looked at it as this magic, pill that would cure everything and I'd lose all this weight and life would be wonderful. And then it's like, you can't stick with it because it's not built to be maintainable. And then it's like all of that shame spiral and just
Mhm.
around and around and around.
And you had eating disorder history before, so that was a familiar cycle.
It was. I had never been, and even to this day, I'd never been given an eating disorder diagnosis, even though now, like with all my knowledge, I'm like, probably unspecified, would
Yeah.
fit for a lot of what I went through. But I think because my BMI, again, was kind of in this more, over the realm of normal range. I don't think any providers were really concerned, even though they should be and should have been. I really think that prevented them from even being that concerned about it. Like, even when we were searching for the diagnosis, I remember my mom would come to visits and they'd be like, well, you just need to, like, you know, eat more or eat less and exercise more. And my mom would be like, she's not even eating. Like, like,
Mm.
we kind of looked at it from more of a weight perspective at that point, where it was like I kept gaining weight, but I wasn't eating anything. So it was we were seeking out a diagnosis from more of, body image distress and that sort of stuff. And I just remember my mom was like, she's not eating anything. Like, and that just like sits with me so much where like, because of what my weight was, these doctors were just assuming like, oh, she must be lying. Like, she's probably
Yeah.
eating more than she is.
So you were restricting even then and restricting with the goal of weight loss, not losing weight because your body had this insulin resistance. That's got to be so frustrating, shaming, and tough that like experience of I'm actually doing the thing they say to do,
Mm-hmm.
and
Mm-hmm.
my body's just not having it.
Yeah. Yeah. You hit the nail on the head with that. It would often be like it never felt good enough. Like I was like, okay, maybe I'm just not like doing it well enough. Like this is my like the proverbial like cross to bear, I guess, that I have, and I just have to work harder. And I would do Weight Watchers and different things, and your weight's going to fluctuate normally. Like that's just like how our bodies are. But I remember the slightest fluctuation, like if I went up, like I would be like freaking out because that was just kind of like, oh, well, I did something wrong then. And it's like, no, like you just didn't go to the bathroom or like your body's fluctuating. Like there was no logic in my mind at that point.
Mhm. Yeah. And you have doctors reinforcing those messages. Well,
Hmm.
there was a moment before when you were talking about the diet you were given, and you were like I'm not even going to name what it is because I don't want to give anyone ideas. And I feel that sort of like it feels like eating disorder world is so touchy. Um, so what was the fear for you in that moment?
Oh, that's a good question. I think like at least in that point, which I need to preface, I don't actually believe this now.
Yeah,
But I think at that point, it was very much of like kind of like I'm trying to think of like the best word. Like, I'm not going to reach my full potential. Like, to me, like what my body looked like and all of like it was so surrounded in body image of what your potential was and like how far I could get in life was based around that. And like, I'll never like meet a partner or have a family or like all of those things kind of like were stuck in that. And I think there
yeah,
was worth that was tied into that too, that I think that was the fear of like, well, I have to do like this is what I have to do. And it sucks that like other people just have it easier and can be in like the bodies they want, but like I have
yeah,
this. Like I'm the exception. I feel like that
yeah.
comes up a lot with clients that I work with now of like I'm the exception to the entire rule here.
Yeah. So this diet or whatever you want to call it, meal plan, wouldn't be enough for most people or wouldn't be satisfying for most people, but my body needs something different.
Hmm. Hmm.
In that moment in our conversation where you're like, I don't even want to say what that is because I don't know what it will do, I guess to listeners, what's the concern? Um, and there's a lot of this in eating disorder, like, don't say this, it's going to affect people this way. What way do you imagine that sharing a just like dysfunctionally restrictive diet that you were given, what kind of effect do you imagine that would have on people hearing it?
Yeah, it's such a good question because, like you said, I feel like in the field we do kind of like um, censor ourselves sometimes
Mhm.
for kind of like safety like even in the same way I'm like I'm not going to tell you what my BMI was or what my weight was like because we
Mhm.
recognize or at least for me it's kind of like
Yeah,
I recognize like through my lens that is a very healed lens, like means nothing to me. Like I have no issue telling you
yeah,
what it was or what my weight was. Like there's nothing from my personal experience that's hard to discuss that. But I
mhm.
feel sometimes like knowing that some clients who might be on, or individuals in general who might be on their journey, like they're looking at things through a very different lens where they might be
Yeah,
like, still thinking that like it's an exception kind of thing like oh well that was great for her but maybe it could still work for me so I'm going to try that and I think
yeah,
that's where me I come from and I often go back and forth like I love this question so much because sometimes I'm like should we censor that like should we be thinking about how every single person is going to think about
yeah,
that or should we just like say it and then kind of be like, if that is difficult for you, like go talk to someone. And I don't know. I don't know if
yeah,
there's like an answer to that.
yeah. I feel that it goes back to the question of like, on one hand, I don't want to reinforce dysfunctional messages about weight loss, food, what you're allowed to eat, what you're not, because we're all getting so much of that already. And on the other side, there's the like, can we get to a place where we can just talk freely while knowing that we're able to work through whatever it brings up for us, for the listener?
Hmm. Hmm. Yeah, I get that. And I think it's so hard. Like I love what you said too of like it is kind of like I don't want to reinforce it, but me just mentioning that that's disordered is not really fully like reinforcing it. Like it's actually me calling it out for like this is a dysfunctional thing to be doing, you
Yeah,
know.
yeah. And that was my thought also as we were talking. So if you were to acknowledge, like I was prescribed and I like if I just totally made something up, but like this amount of food for breakfast, this amount of dinner, this amount for lunch, and this is what it did to me. Um, is there like, is there concern in sharing something?
No, and I think that's like you kind of hit the nail on the head of kind of it has to do with how you present it too, I think, of kind of like this was disordered, this is what I did. Because people, if they want to find, I often have to remind myself of this too, if they want to find something disordered, they will find it. You said we're inundated with
Right.
disordered stuff everywhere. So if someone wants to find it, they will. And I'd rather, now that I think about it too, I'd rather someone hear from me like a
Yeah.
trained professional, like this is disordered
Mhm.
versus, the influencer on social media saying something. I'd rather them hear it from me.
Yeah, that makes sense. Yeah. It's interesting because I'm feeling a little bit of that hesitation in myself. I'm like, now I'm like, since we're like talking around it so much, like maybe we should just say like, what is the meal plan, even though it like
What is
totally
the
doesn't matter, but just to like talk through or
Yeah.
work through what it's talking about. But then I'm like, wait, like, can I ask you what the meal plan was? Like, it feels feels wrong. I don't know. I feel that like, and and as I'm naming it out loud, it almost feels so like just like we're blowing up something really big that and I feel like this happens a lot in the both eating disorder and mental health space of the like sort of language, I don't know, language policing, like what words are allowed, what words aren't, what words, and it is like context.
Yeah.
So
No,
do you
and
want to
I
share what your meal
do.
plan was?
I know. Did I just say what the meal plan was? And I honestly don't remember, like, I wasn't given, maybe I was, but I honestly don't remember like an exact number of you're eating this many calories. So, not gatekeeping that because I don't even remember that.
Yeah.
But the thing that sticks out the most to me about the meal plan was more so the snacks, like I was saying. And I remember it was like something like 6 to 7 wheat thins and like a cheese stick was,
Wow.
and I was like, who's eating 6 to 7 wheat thins? Like I'm totally eating more than those. And
Like
I
of course you want to be
understood
satisfied. Yeah.
like the perspective of we've got a carb and a protein kind of. So I like got that. Like when I look at it now, I'm like, okay, but even when I do meal plans for clients, I'm not like you can only have this number of crackers. I would be like, okay, so like what's
Mhm.
your thought on crackers and a cheese stick? And do you want to throw something else in there that might be a little bit more satisfying, like, some nuts or
Mhm.
some dried fruit? Like, there's this like it's prescriptive, but it's not in a way where I'm like
Mhm.
working with the client on what do you actually want and let's make it PCOS managed versus here I was just told you can only have 6 to 7 wheat thins or Triscuits.
Mhm.
It might have been Triscuits because those were more fiber filled. Um, and
Yeah.
here I'm counting them out into a baggie to take to work. And it's like you eat that in like 2 minutes. Like that's not a snack.
Of course, you're still hungry after. Yeah. I'm noticing now as I'm thinking about it also because I'm thinking about myself, like when I was in the restrictive phase and how I would feel about sharing like the specifics of it. Or like you mentioned, BMI feels even trickier. And I'm thinking about, I realize part of the concern for me is if somebody feels still has that like weight loss is the goal, eating less is the goal, and they hear me sharing what was restrictive for me, I can, or or even like what was a higher weight for me, they can be like, okay, like uh you think that was bad, or like I'm eating more than that, so like I'm not effectively doing the diet, or like I weigh even more than that, or so I can see that. And also I do feel like we can share openly
Mhm.
and work through it and talk through those hesitations as they come up, which I hear you doing when you talk about your work with clients.
Yeah. And I think it is kind of like you had mentioned, like, I know you didn't use these words, but kind of like time and place. Like I know there's like, or like sometimes people will do like trigger warning or like different things. Like it brings to mind, I always forget her name, but she wrote the book, I'm Glad My Mom Died or whatever that title was. I
Yeah.
haven't read it yet, but people have told me they're like, it's very in depth, like even the pieces where she
Mm.
talks about her eating disorder and stuff. And I'd be like, okay, like maybe not a book I'm telling my clients to go read. There's a trigger warning there for a reason. But I think there is a lot that can be gained from people like sharing their stories and
Yeah.
having space for that. I sometimes feel the same way when people, I don't see it as much now, but there was a time where people were very anti um, comparison photos, like in terms of recovery
Yeah.
comparison photos. And I don't have a preference either way on it. But I've seen both sides, and I think it kind of coincides with that too, of like someone sharing their story, but at the same time, someone else might be like, you're glamorizing your eating disorder. Like there can
Right.
multiple sides to like how people perceive those things. And I think we
Yeah.
we often lose sight of the multiple sides.
Yeah. And that's like the essence of what this
Hmm.
podcast is. And that's why, like, I have in the intro to every single episode, like, you might have a reaction to this. And if you do, feel free to share it.
Hmm.
I do feel like we can create a space where we're able to approach each other's stories and identify our reactions as reactions and work through them.
Yeah. I had a client once who, and more so from a recovery standpoint, but they would always be like, when I would say something, they'd be like, I'm having a strong reaction to what you just said, but I'm recognizing that like that's probably a good thing. And it just means like we tapped into something I have to work on. They were very
Yes.
insightful on their journey. Yeah, like that probably means like we hit something there that's worth
That's
exploring.
exactly. So if anybody listening to this hears about the wheat thins and is feeling like really strong, like shame or not enough, like talk through it.
Yes.
Or you can come on here and we'll talk about it.
Yes.
Um, tell me more about what effect that had on you when you were given the wheat thin diet. Oh,
That's what we'll call it, the weekend diet. I think it just kind of, I always describe diets as kind of like we're relying on external factors versus all of our internal factors and cues. And it just really like it did just perpetuate that where it was like it doesn't matter what your body is telling you. It doesn't matter if your body's tired and doesn't want to go to the gym. It doesn't matter if your body's tired and wants to rest or that it's hungry and wants more food. Like this is what you're supposed to be doing because your body is different. Like other bodies don't have PCOS. So this is what you have to do to kind of
yeah.
deal with this.
Yeah.
Uh, because at that point, like I didn't know anyone. Like this was yeah, this was before social media was even like, I think this was like the
Yeah.
age of Tumblr. If anyone out there remembers Tumblr, which was not like a super safe place, I would say, for, body image distress and stuff like that. But
Yeah.
I knew nobody else that had PCOS. It was not to say it's easy for folks today either. Obviously, we talked about a lot of the weight bias and all of that stuff, but I think there's more community because of social media. Whereas for me, I was like, I'm the only one that has this. And like, there's all this shame in kind of my friend group that I have to eat differently or I'm on these different meds. And it was like, just kind of like you're an outsider, you feel like.
Yeah. So it let you know your body's weird, don't trust it, and created a social barrier where you're not able to eat like other people do or take part in social gatherings that involve food in the way other people do.
Yeah. Or it was like, okay, if I'm going to, then I'm going to feel real guilty after this that like I shouldn't have done that. So it was kind of like, felt like a
Yeah.
lose-lose either way.
Yeah. At what point did you start to snap out of that, or what pulled you out of it?
Oh gosh. I mean, it continued for a long time. And I would say, as kind of disordered eating and eating disorders kind of shift and change over time too, like it did for me. Like I would go through the like, F this, I'm not going to do it anymore. I would go through like, I don't want to call it binging because from like a diagnostic criteria, I wouldn't consider it binging. But there was a lot of like the emotional maybe piece of binging when it would
Yeah.
come. Honestly, it was because I was restricting all day, and that's why I was eating
Right.
more. night. But there was a lot of that dynamic for a while. Um, I will say towards like later college, like my priorities were like, it's junior, senior year. I'm hanging out with my friends. Like this is the last time we're gonna live the way that we do, like a college life. So I just kind of like threw it to the wayside for a little bit. Kind of like how that pendulum swings. So it was like, well, I'm not going to go to the gym at all, and I'm not going to do anything with food, like one extreme
Yeah.
to the other.
I'm done with all this. I can't keep up all of this restriction. I can't keep containing
Mhm.
myself and my body in that way.
Yeah. So that lasted for a while. I got into very crazy bodybuilding in grad school. And like that's a whole, you could do a whole episode on that with someone too. Like that's a whole other area of chaos and odd things. Um, and again, it just all stemmed from like, I'm different, and this is the only thing that's going to help and manage this. And I even remember being so stuck in that and being like, even telling, I mean, now my husband, but my then boyfriend, like, well, this is what I have to do for the rest of my life. Like, there's no way that I will be able to manage this by not being rigid and, counting whatever it might have been, like macros, calories, etc. Um,
Yeah.
and just that sense of like, there's nothing outside of this, right? Like, this is what it has to be. And I think it was just like priorities took over, like for me. And I know this isn't the case for everyone, but it was like, yeah, like I wanted to do more things with my boyfriend. I wanted to do things with friends. Like I had to pass grad school, which was not easy
Yeah.
to become a dietitian. So, like, those things kind of took precedence. Um, and it kind of helped me put a lot of the other stuff to the side. I'm not saying it was easy, but it kind of was like, I'm losing this unless I change things for myself.
Yeah. So that was before you had any sort of framework for understanding the ways that what you had been told were flawed, but it was just like, I can't do this anymore, and I have other things that matter more.
And I was starting to hear a little bit about Haze, like on social media. I didn't hear about it at all in school. I mean, I did my whole thesis on eating disorders. So there was some understanding of eating disorders, but I never felt like, oh, I'm struggling. Like I felt like, well, this is self-directed. How could I be struggling? That makes no sense. Um,
Yeah.
but I was starting to hear from like certain students about Haze. I know one of my friends who has her own practice now, and was a year ahead of me, was like, why don't you just come over to my house and I'm going to show you like the intuitive eating workbook? And I was like, okay. And she was just like, yeah, like this is how I practice. And I was still in school because again, she was a year ahead of me. And I was like, this is fascinating. Like, so that was kind of like a little introduction around the same time, but I think it was just in a positive way, like a perfect storm.
Yeah. I have a really pressing question. And this comes up with diabetes as well. I've heard it from people where they're like, okay, like food restriction seems to be working. My like A1C levels or like things are starting to look right. Was there anything like that for you? Like, was there any decrease in PCOS symptoms or any signs that things were getting better when you were keeping to this restrictive diet? Or was it not even that?
No, I mean, there were some instances. I think it's so hard, at least in my story, because there were so many different things that they were doing medically that I'm like, why are we doing five things at once? You have no idea what's working. Like there were different
Yeah.
medications they would put me on and different things. Um, I was definitely like on and off of birth control throughout that, which alters everything. Um, so there were definitely times where we felt like, oh, this is helping a little bit, maybe, but nothing that I
Yeah.
felt like magic. Like, I mean, and not that there is like a magic solution, but kind of, it never felt like there was something that really like worked. Like all the
Yeah.
different things, never felt like it really did anything.
Yeah. So when you dropped the food restriction, you didn't lose anything massive. It wasn't like suddenly your symptoms were much worse and like, yeah.
No, and I mean, if anything, I kind of felt like the same old, like I lose my identity in this and had to kind of like rebuild that. But from like
Yeah.
and that's where PCOS can wax and wane too. Like as we age, our hormones change. We know that. Like there's even been some talk about like women who are in their later 30s and early 40s, like surprisingly getting pregnant because
Mhm.
again, like your hormones are shifting, you're in perimenopause or you're in menopause, or getting
Yeah.
close to that. So kind of saying like some of the PCOS symptoms decrease for some women at that point. Um,
Yeah.
so there is a lot of talk, and on my end too, I'm not sure, like, was this all PCOS like back in the day? Was it something different that they just never figured out? We don't really know. Like I can only go
Mhm.
with what I know right now, which
Yeah.
is like the diagnosis you gave me, and I kind of like live my life trying to manage that. But yeah, like I would say if I had to, if the Rotterdam criteria were something that they talked about ever at the point in time of my diagnosis, like I probably would have had, I know I had cysts on my ovaries and I know I had irregular cycles. I didn't really have a lot of those elevated androgens, um,
Mhm.
those
Yeah.
symptoms. So that's kind
Mhm.
of where I go right now. Um, at some point,
So
probably.
you found some things that are helpful, some things that change with age, and sort of like if that was what your PCOS diagnosis gave you, beyond all the dysfunctional food patterns, like it gave you some direction in that sense, but there was no clear answer.
No, no. And there were times too where I was like, okay, like I think it was hard to find people that effectively treated PCOS. Like when I was in grad school, I didn't have a ton of disposable income, so I was relying on whoever took like insurance and going
Yeah.
to, like endocrinologists and stuff, and they just weren't that great. And I was really searching for kind of more I had done like the metformin and I had done the traditional meds, and I was trying to look for more of like the supplements and different things, like, and just learning more about it. And I kept
Yeah.
getting told like, we don't do that. That's not like regulated. And I was just like, okay, well, I'm gonna go like continue to do my research. Thanks. And
Yeah.
will say all of those things. It's not that they're, I mean, yes, supplements are not regulated by the FDA. Avasitol and their company, I would say, is reputable because they're third party tested. But like all of these things, we know they're not dangerous things for me to say, like, increase your omega-3 consumption and let's see how that helps.
Right.
These aren't like crazy, like radical things we're asking people to do.
Yeah. I feel like I want to go into the fertility thing, and I feel like there's so much we can go to there, and
Mhm.
we don't have much time. But the the belief that for fertility treatment you need to lose weight.
Mhm.
Uh, where does that come from? What have you come to believe about it? And real quick, and then I know
Yeah.
it's like opening a can of worms right before we have time to explore it, but
Yeah, that's fine. I honestly have no idea where it comes from. I think it's just fat phobia, honestly.
okay.
Because we actually have studies that prove that weight like really doesn't affect your fertility. And this is not to scare people. People still get pregnant at older ages, but like age is the number one factor that impacts fertility rates. So telling someone to delay fertility treatment to go lose weight actually sets them like you're spending more time and aging more, which depending on where you are on that, age spectrum, you're kind of pushing someone possibly into a range where it is harder to get pregnant already. And I don't know. I think it's like BMI. Like we know BMI is not an indicator of health, but we keep using it for unknown reasons.
Yeah, okay. So it was sort of just commonly accepted wisdom for a long time, and it takes time to negate that or move
Yeah.
away from it.
I'm sure there's other like biases within the fertility sphere. Um,
Uh,
just like there are in every sphere, I would imagine. Um, and I don't know, I don't want to like, I feel like when I say this, people are like, are you anti-fertility support? And no, I'm not, but I think you got to think about who's making the money off of it. And I'm not saying people in the fertility sphere purposely, would do anything like that, but I think the system as a whole is kind of designed in a way to make money off of helping someone, get pregnant and achieve fertility. And it's amazing we can do that. It's awesome science and medical advancements and stuff. But I think there's also a huge power dynamic in it that doesn't get really discussed as often as it should.
Yeah, I really want to go more into your personal experience around that, but we'll start to wrap up.
That
What do
sounds
you want
good.
to leave our listeners off with if anyone listens to this who's struggling with PCOS or who works with people who are PCOS or fertility?
Yeah, I think a lot of it is just either one, if you are not Haze aligned or haven't learned about it, like definitely seek out education in that area because I think it is like I give it the gold stamp of approval for care when it comes to PCOS and stuff. But I think just being client centered, like if you don't have PCOS or you don't have that lived experience, like there's a lot that you might not know that someone has gone through. Um,
Yeah.
just encourage people to like be curious with their clients and, you know,
Mm.
accommodating and supportive to them. Because I think that's what everyone, but especially folks that struggle with PCOS really need.
Yeah. And where can people find you if they're more interested in your work or want to learn more?
Yes, so I am Note to Self Nutrition on Instagram. You can find me there. I'm trying to think if I put the LLC after it or not, but I don't think I did. Um,
Send me a link and link it in the
yeah, we'll link it just in case I'm forgetting the LLC on it. But that's usually where I am, or my practice Note to Self Nutrition and my website.
cool. Thank you so much, Lauren.
Thank you. This was great.